I now ask Dr. Gaurav Luthra to start his talk. I mean, everybody knows Gaurav. He got that Pearl Award from the IOS committee yesterday. Brilliant anterior segment cataract refractive surgeon. He's been a dear friend for many, many years. Over to Gaurav.
Thank you, Kumar, and very good afternoon to everyone. And with very interesting course, and it's like a specialized course by Dr. Kumar here. He also presents this course in the European Society and the SCRS as well. Very successful run courses there. So he wanted me to take out a few of these, subluxated IOLs. So I thought I'll just show some, after all those really complex surgeries from the top surgeons, I'll show you something straightforward and simple. So this patient presented to us with a decentered kind of, post. Um, he had been operated elsewhere and had been, had an IOL which was slightly dislocated to one side. We could see a big PC rent visible to the side where the IOL had dislocated. And there can always be this vitreous which may be present. So one has to be very careful checking it. And if you have vitreous, then the first thing that you have to do is make sure that you've cleared all the vitreous out from the anterior chamber and with whatever is kind of surrounding the lens. And the surgeon who had done the surgery had been wise enough to put in a 3-piece lens, but incidentally, because the PC rent might have enlarged, so it had got dislocated. Now if he had done this optic capture, anterior optic capture, nothing would have happened. The IOL would have remained nicely in place, and all I had to do in this situation was just to clear all the vitreous and then just relocate this lens. I didn't do much, and you can see how beautifully it is centered. So it's just an anterior optic capture which saves the day, and no complex surgery is required. So sometimes the solution is very, very straightforward if you do it right and understand it right. Now this was another patient. You can see a small CTR eyelet here and an IOL which has dislocated. Now for this patient, apparently the bag was already slightly lax, and the patient had been operated a few years back, was doing extremely well for almost 7-8 years. She gives history of having gone to a doctor and got a YAG capsulotomy done, and post YAG capsulotomy she started seeing double, and her single piece lens which was in the bag with the CTR through that big capsulotomy. So the trick is to make a small central capsulotomy. That's all that is required. So if you do a big capsulotomy, the lens can, in such situations move about, especially some of the hydrophilic lenses are more prone to do that, but this was a hydrophobic acrylic. So we had a big PC break which was almost as big as that, and through that the IOL had gone behind the bag, and I thought I would again have to probably do something similar to the previous case, but when I went in I saw that there was no vitreous, I think. So we just had to hold it with a forceps. So here you don't need to use the dialer or the other instrument as I showed in that previous case. You can use these MST forceps which can be, so I just negotiated the lens forward. I didn't bring the haptics forward, again an anterior optic capture, because now the capsular excess is fibrous, so it's easy to capture a single piece lens. Otherwise it's not very easy to do an optic capture because they are posterior angulated lenses. So it's difficult to kind of do an anterior optic capture, but here the fibrosed rhexis was able to hold it nicely. The patient did well. There was very little intervention. So she had been told by several surgeons that you'll have an IOL explantation and a glued IOL and refixation and all that. And I finished the surgery in 5 minutes. She thought I'd done nothing, and she was not convinced that surgery was done. So this patient presented to us. You can see there's a CTR in the bag. The whole capsular bag complex has dislocated. I decided to refixate this bag complex. So we are making a Hoffman's pocket. Wherever possible, I don't dissect the conjunctiva. I just make a small groove at the limbus and dissect a Hoffman's pocket. It's quite elegant and it's clean. And the idea was to pass a suture through the. So it's very easy if you have a CTR in the bag and the bag is fibrosed. All you have to do is pass a suture around the CTR and then anchor it to the sclera. It's pretty straightforward. As you can see, I've passed the Prolene needle and railroading it into the bent 26 gauge needle. One suture is out of the Hoffman's pocket, and then I'm going to pass the second suture, and there goes. And once they're out, you will essentially have to just retrieve the sutures from the pocket. And one has to be very careful when making these pockets that they are of the correct dimensions, because if your suture is passed too posterior and not passing through the pocket, you will have a problem finding the suture later on, and then you can be in soup. So you have to know the landmarks and you have to mark out till what depth you have passed the Hoffman's pocket. Otherwise, there's a good chance that you will go wrong. So here, using a small manipulator, I have retrieved the 2 loops of the suture, and then all I have to do is just tie these sutures after snipping them. And once you've tied the suture and buried it into the Hoffman's pocket there, you just trim it, and it comes out quite beautifully, and the bag is refixated over there, and in the end I do an OCT to see whether the optic is well aligned, and maybe put a little bit of pilocarpine and see if it centers well and the posterior capsule is clear in the middle. It looks good in the end, so that's how we leave it. Now this was another situation where to begin with it was a cataract surgery, and later on it became more of a surgery which required something which is the topic of the course today. So this was a pediatric cataract, and we started off by aspirating. This was very intumescent lens, so once I started the rhexis, I did some aspiration of the cortex under viscoat, and you can see that I am now enlarging the capsulotomy to the desired size. But in spite of all my efforts of enlarging the capsulotomy, I feel that we were left with a slightly smaller capsulotomy than what we needed. And I do try to aim for a 4.5 millimeters capsulotomy, because in pediatric cataract sometimes later on the capsulotomy will enlarge a little bit. Now decided to go with a 3-piece lens as I would normally do for such patients, and the white to white was adequate, so I decided that this lens can go into the bag. This child was about 1 year old. So first thing that went wrong was that my haptic, which had gone into the sulcus and I wanted to place it in the bag, I was having trouble retrieving it because it probably went to the edge and went through the zonules at some point. So when I tried to retrieve it, the bag was coming along with it. So there I should have switched to a forceps long before. The easy thing is to just go there and hold it with a forceps. A glue dial forceps would be just right, and just bring it, retrieve it. Here I'm able to finally do it, negotiate it into the bag, and then negotiate the optic into the bag. So the optic did go in after a bit of coercion, and now I want to put the second haptic. You can realize that the bag seems a little too small because the optic went in with difficulty. I'm trying to put the second haptic into the bag, but it's not going very easily. There's manipulation and it tends to just pop out. I decide to use a dialer or a Y-tipped manipulator to dial it in, and as I dial it in, I realize that something is wrong. There's a PC blowout because the IOL is too big for the bag. So now I have a dislocating IOL, which is now pointing, and I have a small rhexis through which I have to retrieve this lens. The rhexis is too small for me to manipulate it out very easily, and the lens, the optic has gone behind the PC actually in this area. It may not be visible on the video right now, but there's a big PC break like this all across. So what I do is, I now need to enlarge my rhexis. So I just give it a small snip because I want to get this optic anterior to the second snip on the other side. Found it difficult to make, so created a small another port, and now I have a rhexis which is about 5 millimeters in size. Now I'll go with the forceps and make sure that I'm not making mistakes, because this IOL can sink, and get the one haptic out, keep the lens stabilized, pass on to the other hand, and then using a second instrument get this thing anterior to the bag through the smaller rhexis, because the rhexis is still smaller than the size of this optic. So negotiating this optic anterior to the rhexis, changing hands, and now going from the other side with the glue dial forceps and getting the second haptic a grip on that, and now I'm secure. So I'll just have to dial that out and position this IOL into the sulcus. So you have to be prepared, and the correct instrumentation plays a big role. See, I'm now holding with the forceps and placing the haptics into the sulcus rather than trying to dial it in. And once that is done, now I have to do an optic capture. So putting in the second haptic now from the other side. So the IOL is now nicely sitting into the sulcus, but to lock it in, I'll just do a capture. The optic capture will happen fairly easy, and now the IOL is locked in. So you can, in pediatric cataract, it's not over till it's over. So you have, it can take time, but you have to ensure that you do a good job. And Now the last video that I thought I'll share with you if I still have time. This is something which was referred to us by one of the colleagues. He had a dislocated multifocal IOL of some kind. I think it's a Rayner multifocal of the older design sitting on the retina. So of course it has to be, after vitrectomy you can retrieve it and bring it up with one of your hands, and then since it's a straightforward single piece design, not ideal for the sulcus, but all you have to do is you have a fibrosed capsular excess, you bring it anteriorly and just, since it was, the other eye also had a multifocal lens, we didn't want to explant this lens and put in a monofocal lens, and it seemed much easier to just negotiate the lens and position it in the sulcus and see if it sits nicely. And yes, it did, and that made the task much easier, and the patient was also very happy because he got his vision back. And with that, I think I'll stop. It looked good post-operatively, and with that I'll stop. This is another one, but I think we've already covered much of this, so thank you so much.